with the Shelbourne Knee Center podcast, and tonight we're doing another episode of Patient's Place. These are episodes that are specifically geared towards patients for specific conditions to try to boil things down in simpler terms for non-clinicians to be able to listen and maybe learn and maybe try to remember some things that were told by your doctor in your visit. So if you have a patient that has one of these conditions and you want to use this Patient's Place content to reinforce things that you've told your patients, or if you're a patient yourself and you just want to learn a little bit more, we hope you'll enjoy this content.
So in tonight's Patient's Place episode, we're going to be covering MCL tears and how to handle those and what to expect when you sustain one of those injuries. Very similar to the Patient's Place episode we did last time, which was the PCL injury. So we're going to have a similar conversation. We're going to jump right into it. And Dr. Benner, a lot of times with these Patient's Place episodes, we really set the stage by talking about some causes of the condition or injury or what the signs and symptoms may look like. So let's just jump right into this Patient's Place episode of MCL tears or injuries and first of all, discuss how these are typically sustained for patients.
It's one of the most common injuries that we see athletes have or in the general population have. You know, it's a very common one. It's kind of like an ankle sprain for the knee. It's just something that a lot of people have experienced before to varying degrees, and we'll talk a little bit about that later as well, but something that's very common. Usually it happens by a very predictable and very reproducible mechanism. So in order for you to tear the medial collateral ligament, which is what MCL stands for, it's the main stabilizing ligament on the inside of the knee, to injure that, you have to do something that distracts or pulls apart the two bones on the inside part of the knee. Usually that happens with the foot on the ground, and usually that happens with a blow to the outside of the knee. So one of the most common places we see this is in offensive and defensive linemen in football, where you're locked up with a defender, maybe as an offensive lineman. The knees are kind of out straight with weight on both sides, foot on the ground, and somebody falls into the outside of the knee. We don't see this really on the outside of the knee. The outside ligament structures of the knee are much less likely to be injured because you don't really get hit on the inside of the knee. If you get hit on the inside of the knee or somebody's coming from that direction, usually they'll run into the other leg before they'll hit the inside of the knee. So it's much more common to get hit on the outside of the knee, have the knee kind of collapse inward into a more knock-kneed position and pull the two bones apart far enough to tear or somehow injure the main stabilizing ligament on the inside of the knee, which is the medial collateral ligament or the MCL.
Now, if a patient sustains an injury like this, what types of symptoms or signs are they going to be dealing with immediately after the injury, and when do you typically see these patients in the office after they sustain that injury?
The main symptom that we see is pain on the medial side of the knee, the inside part of the knee, and patients will tell us that this hurts a lot, even though it's a relatively minor injury and is much easier to take care of than some other knee ligament injuries that we see. It is still very painful. A lot of times patients will say, well, I was locked up with somebody and somebody fell into the outside of my knee. I felt my knee go inward and I felt a pop on the inside of my knee and immediate onset of a lot of pain on the inside of the knee. So often it will be a big deal injury, but sometimes it'll be a relatively minor injury where someone says, yeah, I got hit on the outside of the knee. My knee went inward a little bit. I walked it off a little bit and I was able to keep playing or able to keep doing the activity that I was doing. So it does kind of vary with regard to severity, but sometimes I think patients think, well, it's got to be something more than an MCL tear because it hurts so bad. And that's not necessarily the case. Sometimes MCL tears can't hurt very badly, but that's usually what patients are complaining of is pain on the inside of the knee, maybe feeling a pop and feeling the knee go inward after the foot being on the ground and someone falling on the outside of the knee.
Now, with these types of injuries and conditions, oftentimes we talk about some differential diagnoses and what else it could be. And now on this Patient's Place segment here, this is our now third installment of a knee condition that could potentially manifest itself as medial knee pain or inside of the knee pain. The first one being osteoarthritis is a very common location for that. And the second one we went over was degenerative medial meniscus tear. So knowing that this is another condition that will really manifest itself as medial or inside of the knee pain, is that oftentimes you're discussing that with them, or just for the patient's sake on this episode, is this ever a non-injury condition, and what could that also be if they're having medial knee pain and they Google it and they see, well, MCL tears are medial knee-sided or medial-sided pain, maybe that's it, or is this always an injury case like you talked about with the defensive and offensive linemen?
Yeah, it's most all the time a pretty open and shut thing from a diagnostic perspective. That if somebody says I got hit on the inside of the knee, felt like my knee went inward, felt pain on the inside of the knee, with that history just in and of itself, you can usually make the diagnosis that it's probably an MCL tear. Now, a lot of people come to the office regardless of what the mechanism of injury is. If they have pain on the inside of the knee, they look up pain on the inside of the knee on the internet, and Google spits back out to them that they could have a medial meniscus tear. So that's often something that the patients will say when they first come in. They'll say, well, I had an injury to my knee. I went and saw my athletic trainer or our sideline doc or my primary care doc or just my family member who's had knee problems before. They said I probably have a meniscus tear. To the contrary, meniscus tears are very uncommonly traumatic, usually unless they happen at the time of an ACL tear. So if somebody doesn't have an ACL tear and they say, I hurt my knee at this specific time when it twisted this way, or I landed on it this way, or more importantly, if somebody falls on the outside of the knee, usually it's not a medial meniscus tear. But that's, like you said, that's something that people often go to when they have pain on the inside of the knee. But usually from a diagnostic perspective, if you talk to the patient and find out what happens, usually it's pretty open and shut as to what the diagnosis is.
So before we jump into the examination and what you would do with the patient that comes in with this type of injury, just wanted to touch on that mechanism again. And you had mentioned taking a direct blow to the outside of the knee, for example, like an offensive lineman in football. But are there any other mechanisms that you have seen, whether that be contact or non-contact, and as it pertains to an isolated injury or that which occurs with another ligament in the knee?
I have seen non-contact MCL injuries. They're very uncommon, but usually it's foot on the ground, somebody falls into the outside of the knee. I've seen it in wrestlers when people get maybe the inside of the foot on the ground and then get thrown to the outside where the inside of the foot stays on the mat, and the rest of them, like if you put your right foot, kind of turn it inwards so the inside of your foot's on the ground, and then your body gets turned over to the right to the same way. That I've had people tear their MCL that way. Very similar mechanism, but that's not somebody falling on it. And then I've had a few people that have just twisted their knee awkwardly and had an MCL tear, something that when I initially listened to them, did not think that was the diagnosis. And then either via MRI scan or via physical exam, we figured out that was ultimately the diagnosis. So not 100% of the time, but the vast majority of the time, it's somebody hitting you from the outside of the knee. And if it's part of a multi-ligament injury, all bets are off as far as mechanisms. If it's in a car accident or a fall from a height or something like that, sometimes patients won't have that exact mechanism, but the MCL can be involved in multi-ligament injuries as well.
So now once you do get the patient in the office and they have one of those varieties of mechanisms of injuries that you just went over, what's your examination look like? And that can be just from a conversation you're having with them, and then from a physical exam point, what would you say that the patient should expect?
As always, we start on the opposite knee. We always go to the uninjured knee first, check full range of motion, and kind of establish what is full range of motion for that patient, what full hyperextension looks like on the uninjured knee for that patient, what full flexion looks like on the uninjured knee, and then a full ligamentous exam. So you're doing a Lockman, you're doing a posterior drawer, you're doing varus and valgus stress testing in order to assess the ligament stability on the uninjured knee. Dr. Shelbourne's always taught me to do the medial side soft tissue examination differently. I was always told to just do a regular valgus stress test where you stand facing the patient, lift the leg up, put your outside hand on the outside of the knee, inside of the hand grabbing the leg, and then just push the knee into valgus, and then slide your fingers behind the knee, bend it up to 30 degrees, and repeat the same thing. What Dr. Shelbourne's taught me to do is to do that, kind of turn your back to the patient, lean the knee up against the side of the table, and let the patient's foot kind of come down off of the table. So you're actually stabilizing their knee between my thigh and the table and putting my hand on the top of it. So the patient's thigh is still on the table. The patient's leg is actually off the table with me holding it, of course, because it could be painful. And then holding the leg there and then pulling the knee into valgus against my leg. So the one thing that does, and I kind of do both. If I think patient has an MCL tear, I'll do both exams. But the one where you drop the leg off the table, kind of pin their thigh and knee against the side of the table with your hand, and then pull the knee into valgus against my knee, that's better to kind of relax their muscles and hopefully get them to really focus on whether that's painful on the medial side and whether or not they can relax enough. If you lift the leg up, sometimes even though you tell the patient to relax, sometimes it's difficult for them to relax. when you're lifting the leg up, versus if you set the thigh down on the table, kind of pin their leg to the side and then grab the leg. Usually they can really relax the leg and make that exam a little bit easier. But really, valgus stress testing is really the biggest thing that you want to do, and make a side-to-side comparison. And we always want to do that at full extension, at full 0 degrees extension or full hyperextension, and then about 20 or 30 degrees of flexion. Flexing the knee for 20 or 30 degrees really helps to loosen the posterior structures in the back of the knee. And if the knee is all the way out straight, sometimes you'll get a false sense of stability because the structures in the back of the knee are tight. So if you bend the knee down a little bit, about 20 or 30 degrees, it relaxes those structures, isolates the medial collateral ligament, and then you can do a side-to-side exam and see if there's a difference. Now, if the patient is unstable at full extension with the knee all the way out straight, if they're unstable medially, that suggests that there could be involvement of one of the cruciate ligaments as well, an ACL or the PCL. And that's kind of what we run through with from an exam standpoint.
Now, with those exam procedures, what are your key findings to make you think this is a MCL tear? Now, obviously, the story has a lot to do with that, but from a physical exam point, what are those key findings that, again, point you towards this diagnosis?
Yeah, you're right. The diagnosis is really made by discussing it with the patient and hearing about what happened to them, but then it's confirmed by the physical exam. And if you do the examination on both sides, you should notice a difference in laxity or looseness in the medial collateral ligament on the injured side versus the uninjured side. So you do the valgus stress testing at 0 and 30 degrees of flexion on the uninjured knee and the injured knee, and see if you get more medial opening or valgus or knock-kneed instability on the injured knee versus the uninjured knee. And then from there, you also want to know whether or not it's painful. If somebody has had an MCL injury in the past that has already healed, so if somebody had an injury 3 years ago and then they hurt themselves and somebody thinks they have an MCL tear, but when you stress it, it feels loose but does not hurt them at all, then it's possible that can be just residual looseness from a prior injury. So as you're putting them into valgus and pushing, looking for a new MCL tear, in addition to increased looseness in the ligament, it should also be painful. The one other thing that I left out when I was setting the scene for a physical exam is just palpation as well. I mean, something as simple as just palpating the medial side of the knee, the inside of the knee on the uninjured side and the injured side, and having tenderness when you push on the injured knee on the inside.
Now, when you talk about the valgus stress and you talk about increased laxity side to side, I think about gradations of injuries, and whether somebody again has Googled it or they saw on ESPN that somebody had a grade 1, 2, 3, and I like how you compared it to an ankle sprain of the knee. It's just a big ligament on the inside of the knee, very similar to a lateral ankle sprain where you're doing the same thing to the outside of the knee or outside of the ankle. But again, you always read or see about or hear about grade 1, 2, 3. So from a physical exam standpoint, can you describe what those grades mean? And then from a structural standpoint, what are the differences between those grades?
There's a couple different grading systems, and I've kind of used both, and I think it makes it a little difficult sometimes because surgeons do use both grading scales. I think if you have less than 5 millimeters of opening with the valgus stress, that's considered a grade 1. If you have 5 to 10 millimeters, that's considered grade 2. And if there's greater than 10 millimeters of medial side opening, that's considered a grade 3. Now, you can't really make those measurements when you're just pushing on the knee. So I find that one to be not very useful. I think if you're doing image guided stress testing where you're doing stress x-rays, then you can actually measure the difference in the opening on the medial side with and without stress. Then I think you can use that. The one that I find to be a little more useful is where grade 1 is just pain on the inside of the knee, but it's not unstable. So if you push on the inside of the knee and it hurts, and their history suggests an MCL tear, and you push the knee into valgus and it's painful, but it's not unstable compared to the opposite side, then I would consider that grade 1. Pain without laxity is grade 1. Pain with laxity but having an endpoint is grade 2. So if you push on it and it's looser than the other side and it's painful, but you do get to an endpoint where it stops, then that's grade 2. Grade 3 is where you have complete loss of medial side stability, where you feel like you could keep pushing forever and there's not really anything stopping it. And also another component of grade 3 laxity is also any looseness at 0 degrees of extension. So these grading scales are all really taken at 30 degrees of flexion where it isolates the MCL. But when you have grade 3 laxity at 30 degrees, usually you will also have some laxity at 0 degrees.
Now, I know this is more semantics, but I know that patients really question this a lot when you start talking about the gradation of any type of ligament tear. And we use the word tear, and the patients, again, get hung up on that and usually question that. Well, when is it a sprain? When is it a tear? And second question is, does that change the prognosis at all?
Yeah, it's interesting when patients talk about, well, is it sprained or is it torn? And what they don't know, we often have to educate them on. And honestly, a lot of clinicians don't know is that a sprain is a tear and a tear is a sprain. Those are used interchangeably. The tear that people are most likely talking about as opposed to a sprain, I think people really mean a complete tear or a partial tear, I think is what people are really after. While those are both by definition kind of sprains, they're different grades of a sprain. So a complete tear is actually a grade 3 sprain. So in grade 1, I think there are just some where it's just painful, but it's not torn. I think there is some damage within the fibers of the ligament, but the ligament hasn't gotten any longer or looser than it was previously. In grade 2, there is enough of an injury where it has made it looser than the opposite side. In grade 3, it is completely torn and there's no stability there as well. So, I think people do get hung up on, well, if it's an MCL tear, how bad is it? How bad a one is it? And what that doesn't necessarily change a lot from a clinical standpoint as far as what we do, but it does change our prognostication, if you will, on how long it might potentially take them to get back.
So after you have this patient and you've done your evaluation and you're pretty certain that this is an MCL tear, are you moving right to treatment, or do you have to get any type of imaging for these patients?
Well, we get imaging for almost everybody that comes in the office. Almost everybody gets an X-ray. If they've had them from outside, we'll review those. But if they don't, then we'll get them in the office. And we just want to make sure they don't have a fracture. They don't have any kinds of bony abnormalities. So from an imaging standpoint with plain radiographs for an MCL, I guess it's possible you could see a little bit of gapping of the medial joint space. But especially if you get weight-bearing X-rays like we do, I don't think you'll necessarily notice any abnormalities for an isolated MCL tear on plain radiographs. You can get an MRI and see MCL injuries. And, when I used to take care of a Division I team, a lot of those patients ended up getting MRIs, not necessarily because I wanted them to or needed them to, but because a lot of times coaching staffs and players' families and players wanted, well, when am I going to get my scan? All right. I kind of capitulated to that over time. I used to, stomp my feet and say, you really don't need MRI scan. But after a while, it's just, that's a discussion for another day. But the imaging's kind of become ubiquitous across, collegiate and professional sports that you just are, it's just expected that you're going to get some advanced imaging. So, MRI scan is not radiation, doesn't cause any harm. So, a lot of times we'll end up getting them. And that can tell you where the injury is. I think the more proximal MCL injuries are more likely to heal very quickly and be stable quickly, but also get very stiff, versus the mid-substance ones are probably in the middle of that spectrum. And the distal ones, the ones that are off the tibia, those can take a little more time to stick down and more likely to feel a little bit more unstable early on. Now, does that mean I think everybody needs to get an MRI scan in order to know where it came off of the bone? No, I don't think that's necessary. And we almost never get MRI scans for an isolated MCL injury. But if you do, that's some of the information that you can get from it.
So now I think you've done a good job talking about the exam and the diagnosis. Let's get into treatment. You talked about, the gradation may not matter from a treatment standpoint or what your decisions may be, but what are those decisions? So let's take a case example. If you have somebody with a middle of the road grade 2 MCL tear, for example, you have this patient in your office next week. What is the first thing you're telling them from an education standpoint? And then what's your treatment plan for this patient?
A lot of times I try to use that physical exam to show them, in addition to what I'm feeling and thinking about it, actually show the patient, you see on this side, I push there and it barely moves and that doesn't hurt. On this side, you feel the difference there. Patients are like, oh yeah, that definitely feels different and it's painful. So as I'm doing the physical exam, I'm also trying to educate the patient on what's going on so they can feel what I'm feeling. And when I start describing it, they can match that in their minds with what they feel. From a perspective of how do we treat it, the good news is that MCL tears are almost never a surgical problem if they're in isolation. So an isolated MCL almost never needs to be fixed surgically. So that's the main things that I tell the patients. The bad news is you have an MCL tear. The good news is that this will almost certainly heal on its own, even if whether it's a bad one or not as bad a one, it will heal on its own with time and become a good knee again. Now, it may heal with a little bit of laxity. So you have to tell them that even though it heals and it won't hurt or won't really cause any problems, you may still be able to kind of move the knee inward and feel a little bit of a difference side to side. I usually try to tell patients this is a kind of by definition a day-to-day injury. If you came to me, regardless of how loose your knee was, if you came to me tomorrow and said, I have this, and this intervention, and the knee doesn't hurt very much, and I went through a functional progression, can I play? The answer would be yes. So, it's much more about how quickly we can get your knee functionally ready to play. So I'm getting ahead of myself, but backing up to when we first make the diagnosis, first is to tell the patient, this isn't going to need surgery. This will heal on its own. So if it's going to heal on its own, what do I need to do to make it better? Well, one is to get your range of motion back. MCL tears, in addition to being sore, can make the knee pretty stiff as they heal. So you got to start working on swelling control and range of motion from the very beginning. And then once the range of motion's back, then we start into some low impact light exercise, and then eventually move on to strengthening. And once the patient's back to full motion, full strength, has passed a progression, then they can return to sport. Now, you notice I didn't put any time limits on that. So if somebody has a grade 2 MCL, or we feel like it's a reasonably bad one, and at 2 weeks they check off all those boxes, then I think we can go let them play. And on the flip side, if somebody has a grade 1 MCL where they don't have looseness, but it takes them a long time to get their motion back, long time to get their strength back, it may take more than that. Generally, while it is kind of a day-to-day injury, if I'm dealing with an in-season athlete, everybody always wants us to prognosticate. Well, you saw the patient 5 minutes ago. Now tell me with pretty good accuracy when the patient's going to get back. It's kind of an exercise in futility because it's hard to be 100% accurate, but we do have to give some sort of an idea. So for a grade 1 MCL tear where it's sore, but it's not unstable, I'll usually say this is a day-to-day injury, and we can probably anticipate return to sport in a couple of weeks. If it's a grade 2 injury where it's a more significant amount of looseness, I think it's more of a question of whether or not they could be back that quickly. It's probably going to be more like something along the lines of 4 to 6 weeks. And if it's grade 3, it may be more than that, up to 6 to 8 weeks. Of course, we also have to take into account with a grade 3 tear that there also may be an associated cruciate ligament injury. And if there is, that's going to lengthen return to play. But in general, that's the time period that I estimate for people. Grade 1, 1 to 2 weeks. Grade 2, 4 to 6 weeks. Grade 3, 6 to 8 weeks. As far as treatment goes, patients don't have to have any structural treatment. So they don't have to be in a brace. You don't have to do anything specific to get the knee to heal. It can heal on its own. However, sometimes if patients have more significant looseness or laxity on the inside of the knee, sometimes it's very difficult for them to put weight on it. And patients will say, well, I know you told me I don't have to have crutches or a brace if I don't want to, Dr. Benner, but I feel like when I put my knee, if I just touch my toe to the ground, I feel like my whole knee is collapsing inward. Sometimes there will be people that have such, extraordinary medial side looseness that there wants some sort of immobilization. So we have the choice of, do we put them in a brace? Do we put them on crutches? Do we restrict their weight bearing? And do we even go to the extreme of putting them in a cast? From our perspective, we've always favored more rigid forms of immobilization. So if I think somebody needs immobilization for an MCL injury, because they say when I put my foot down, I feel like my whole knee's going to collapse, and I'll actually cast them from their hip all the way down to the ankle, a long leg cast without incorporating the ankle to keep the knee very rigidly stable. And some people think that's, casts are archaic and that's an old school way to do it. And you don't need to do that. If you do, you can put them in a brace and let them take it on and off. In my opinion, if you need rigid immobilization in order to get the knee to calm down and heal, then it should be a rigid form of immobilization. So I would say that of the MCL tears that we see, it's maybe 2% of them that we end up immobilizing. The vast majority of them we will treat non-surgically. We will not put them in a brace. And the ones that feel really, really loose, then we might cast them for a couple of weeks just to get things to start to heal.
Yeah, I'm glad you said a couple of weeks, because that was my next question for you. When you have this, let's say 2% of patients that need more of a rigid cast fixation to get that MCL to heal and get the patient more comfortable and more mobile, what's that time frame look like? Is that something where you're casting them and having them come in a week or two later and doing a reevaluation? Or is that a set time period that you have for every patient that you say, hey, come back at this time and we know that it's going to be done for good?
And we usually do weekly cast changes until till the endpoint kind of firms up or till the patient feels like they can put some weight on it. So a patient comes to me in the office with an isolated grade 3 MCL tear and says, I feel like my whole knee's collapsing inward and I can't walk on it. Then I'll put them in a cast. We'll actually sit them up on a small stool up on the exam table, and then we'll externally rotate the leg and put the knee in about 30 degrees of flexion. And by doing that, it kind of puts the knee in the position where the MCL is going to be the loosest at 30 degrees. And it also, by externally rotating the hip and letting the leg sit out to the side, it kind of compresses the medial side. It almost gives the knee a little bit of varus positioning to compress the medial side. And we put the cast on in that position with the knee at about 20 or 30 degrees of flexion and with the knee kind of in a little bit of varus stress. And after that, patients will then be able to walk and put full weight on it pretty easily. There's no reason patients can't weight bear with an MCL tear. It just may feel unstable. So once we take the instability away by putting on the cast, patients will often go from, I can barely put my toe down because my knee feels so unstable, to walking out of the office in the cast. That's the nice thing about more rigid forms of immobilization versus people that are put in a knee immobilizer or put in some other kind of a brace. I just don't think you get to the same kind of rigid stability, and a lot of times they still have to be on crutches, can't get around as well. So even though casts seem archaic and they seem like they're old school and that's an old method of doing things, it's a tried and true method of getting rigid immobilization, making sure there's 100% compliance and that they don't take it off, and be able to put the knee in the position where you want it to where you most want it to be there and hold it.
Now, with this being a condition and an injury that is really a non-operative case where you're waiting for the tissues to heal and then properly rehabbing the patient to get them back to their sport, I think it's natural for people to ask, and it's 2025 and everybody wants things to be faster. Is there any way that the healing process can be sped up, or are the patients just limited by their healing potential of their own body and have to wait till that tissue naturally heals?
I think the short answer is no. I don't think there's a way to really make it go faster. I guess immobilization does. It depends whether we're talking about healing or return to sport, because I do think we can get people back to sport faster with the use of braces. So if a football player tells me they had an MCL injury and it hurts, so I don't think I can play, then we will try them in a brace with stabilizing brackets on the side of the knee and then let them get back on the field and see if they can play. And if they tell me it hurts too much and it feels too unstable, a week or 2 weeks out from injury if I don't have a brace, but when I put the brace on, I feel stable enough and I can play, then a lot of times the bracing will speed return to sport. And I guess, just like ankle sprains, ankle sprains, there's literature that shows us that people will get better healing and better stability after an ankle sprain if you're casted, and that will speed return to play. How often do we cast ankle sprains? Not very often, almost never. So I do think it would potentially speed healing in order to get rigid immobilization, like I think is true of all soft tissue injuries. However, you have to then keep in mind what kind of potential consequences is that going to cause with making the knee stiff, making the muscles atrophy, generating weakness, things like that. So I think for the majority of patients, they'll get enough healing and be stable enough in order to get healing without a period of immobilization. And it's a small group of patients who are really unstable that need the cast.
Well, this next question is going to be a little bit off topic. And in fact, it's almost complete opposite, because now we're not talking about the prognosis of an injury. It's more on the prevention side. But when you mentioned football linemen in particular with braces after they have this injury, I think of linemen wearing these braces all the time. And we've all watched college football Saturdays or NFL football Sundays, and we see these big offensive linemen with these big bulky knee braces. And the thought is everybody wears them, all 5 of them, in hopes that it's going to prevent some type of knee injury. I would assume more like an MCL tear for a majority of the time. At least that's the thought process. So I just want your thoughts on, do those work? Is that something that is recommended, or is it something that's just been done forever so they keep doing it, or what?
Yeah, I think there's a lot of braces that people wear that don't necessarily have any data that show that they're going to make a difference. In knees in particular, we know that people are often told to wear a brace after they come back from ACL surgery, but I don't think anybody's ever really definitively proven that a brace decreases your re-injury risk. You can, and often do, re-tear your ACL even if you wear a brace when you return to competition. So with regard to ACL braces, I basically tell patients, if you want to wear one, you can wear it, but it's not necessarily necessarily been proven that it's going to make you less likely to re-tear your ACL. In fact, if you look at the data, you're more likely to you're more likely to tear your opposite ACL as opposed to re-tear your reconstructed ACL. So the question is, which knee do you put the brace on? You tell somebody they should wear a brace, should have them wear a brace on the opposite knee? Probably, because that's the one that's statistically more likely to tear. But that's a discussion for another day. But specifically with the difference with MCLs is there is some data that shows a decrease in MCL injury risk if you wear the big bulky, lineman braces, if you will, when you play football. That's a specifically dangerous sport for MCL tears, and there is some data that shows us that bracing like that does decrease the risk of MCL tears. So every college team on Saturday, everybody has bilateral knee braces on the offensive line. The interesting thing is, look on Sunday and see who's wearing those braces. A lot of the guys on Sunday, the professionals, aren't wearing those. And Dr. Shelbourne pointed that out to me, and I'm like, that's not true. Those guys surely wear braces. And I flipped on the TV on Sunday and saw very few braces on linemen in the NFL. And I asked him about it. He's like, well, the NFL people are like, you know what? I'm a grown man. I don't want to wear this. I'm taking it off. And I don't think the teams really have as much say over it versus at the collegiate level. It's like, you're 18 years old. You're going to do what I say, put the brace on. We bought these expensive braces. You're going to wear them. So it's kind of interesting seeing the difference between looking at linemen on Saturday versus Sunday with regard to brace wear. But there, in answer to your question, there is some data that shows decreased risk of MCL tears if you wear braces. And if patients want to do it, I don't think there's much of a downside.
So now bringing this back to more of what we were talking about, it has to do a little bit with re-injury. So let's take that same patient we were talking about, more of a case example of a grade 2. You treat them non-operatively. They get back in their 4 to 6 weeks after the injury, and they're practicing, and you're seeing them on, let's call it discharge day, and they're feeling great, like nothing has ever happened. Are you giving them any education at that point of things to look out for to try to prevent this from happening again? And is it statistically more likely to happen a second time if it's happened a first time? Or what are you telling this patient on discharge day?
To be honest, no, I don't really spend a lot of time on education on how to prevent this injury, other than your chances of being re-injured, I think, are less if you get back to full motion, full strength, full function. What we don't want people to hear from an MCL treatment visit is that, well, this is going to heal without surgery. Doc says I'm going to be fine, so I'm good. And as soon as my pain goes away, I go back to play. If you do that, when you go back to play, your knee will probably still continue to hurt, and you won't be as good from a performance perspective. So what can't get lost in this is the rehab criteria of, while there is a time factor associated with it with regard to the soft tissue healing that we can't really change much, if at all. But what we can change is if the soft tissues heal, but the patient doesn't get their motion back, doesn't get their strength back, doesn't go through a functional progression, and just goes back and plays, then I think you're going to have an unhappy patient that comes back to you and says, I still don't feel like I'm right. You told me this is going to get better, and now it's not. So it's definitely an important thing from at the initial visit, really even more than at the discharge visit, to let people know that while this is a non-surgical injury, while this is something that should heal and have good function in the future, it will only have the best function if you hit all the rehab goals that we have, just like any other knee problem.
Excellent. Well, thanks for going over that information. As always, I think these episodes are great for getting a big, macroscopic level picture of these injuries in terms of what to expect at the office visit, what to expect from a treatment perspective, and then importantly, what to expect from a prognosis standpoint. So thanks again for going over that. If you want to see other episodes in the Patient's Place or any of our previous content, reach out to us on our social media pages, Twitter and Instagram at the SKC Podcast. You can look at our SKC Podcast YouTube and Facebook pages, or you can email us at the skcpodcast@gmail.com.
As always, our Patient's Place episodes are for educational and learning purposes only. If you have any specific questions about your care, we encourage you to reach out to your surgeon for more information.